All right, let's continue on our discussion about different types of anesthesia. So we just finished talking about general anesthesia. General is when you're completely asleep. They're usually in some degree of paralysis, asleep, and of course given some medication to make them not remember. But regional anesthetics are done a little differently. One example of a regional is a spinal. Spinal is also called subdural block because when we put in a spinal, we actually puncture the dura mater and put the medication in under that membrane, hence the term subdural. So with a spinal, you are going to be numb basically from the point at which the spinal was placed down. So this person can remain awake if we need them to. It can be done with a little bit of food on the stomach. It's not necessary that they're completely NPO. We like them to be, but it doesn't have to be because, again, we're not going to intubate them. We're not going to, potentially risk that airway. There are no inhaled anesthetics. So if you have somebody with a severe respiratory problem, maybe they've got COPD or asthma or something where they've got some pretty significant issues. The beauty of this is there are no inhaled anesthetics, so we're not going to increase any irritation, we're not going to increase the secretions because we're not involving that body system. Usually the way we look at it is only the necessary region is anesthetized. If we're working on your knee, do you need to be asleep? That's, one of the questions. The two things we balance here are the fact that spinals take obviously a little bit more skill to put in, and it takes a little while for them to take effect. And then once they do take effect, you have, different, of course you have drugs that allow you to decide how much time you need, but somewhere between 1 and 4 hours is how long you're going to get for that spinal. The issue with that is, say you just need a knee arthroscopy, and we think it's going to be a really fast case, like 5-10 minutes. Well, is it better to do a spinal that takes quite a bit of time and finesse to put in, quite a bit of time for it to take effect, and then quite a bit of time for it to wear off at the end? Or in that situation, would it be better to do a general anesthetic where we can put you under and bring you back up all in 15-20 minutes? So usually, we would err on the side of giving you the least amount of anesthetic, which would be a general. But if you complicate that matter and you say, okay, now this person has some severe lung problems and they still need a knee arthroscopy, well, that doctor may change up their tactic then and say, well, okay, yes, it's still going to be a short case, but considering all of the lung problems they have, we're going to switch this over and do a regional. So hopefully I've tried to give you, reasons why they would choose different types of anesthetics. Now, you can determine the length of the block by the choice of drug, as I kind of mentioned a minute ago. Lidocaine usually gives you about a 1 hour's block. So if it's a short case, you can use lidocaine and they'll recover out of that pretty quickly. Marcaine is like 4 hours. So that one is going to be obviously for a more lengthy surgery, or if you need a little bit more time for that anesthesia to work after the surgery. The problem with 1 and 4 hours is, there was no middle ground. We needed something to kind of fill that gap, and we now have it. Tetracaine is a drug that can be used, and it will give you about a 2-hour block. So one of the things the surgeon is going to have to decide in their mind is how long they think the surgery is going to be, and then they'll determine what drug needs to be used based on the length of the surgery. One of the issues that can arise here are the potential for allergies. Many people become exposed to, the cane kind of medications like Novocaine at some point when they've had dental work in the past or something. And there are a lot of people who have allergies to that class of drug. Well, since lidocaine, marcaine, and tetracaine are all in that family, all of those would not be an option then if they were, wanting to use that for anesthesia. Another problem with spinals is when you put the medication under the dura, a lot of people think you're putting it in where, you're poking into the spinal cord. The spinal cord ends higher up than where we're putting this in. All that'll be dangling from that spinal cord are little tendrils of that cord. So it's kind of like these thread-like things. So, you're not going to hit the cord. But what that also means is you might not get an even distribution of medication on all of those little, tendrils that are hanging down. So you can have something called a spotty block. In other words, this person, their left leg may be completely numb, their left hip is numb, but their right leg is only numb in a few places, and it ends up being the right knee you're working on. So obviously that's not amazing. The other issue with spinals is, especially if the doctor has to try a couple of times to actually get in the dura. And how we know we're in the dura is when you puncture the dura, cerebrospinal fluid will drip out of the back of the needle. That's how they know they're there. And then they put the syringe on with the medication and put it in. But if you have to try more than one time, if you've made a couple of pokes in there, the problem with that is cerebrospinal fluid can continue to leak out very slowly, but this can end up causing a spinal headache. And a spinal headache is a direct result of the loss of cerebrospinal fluid, and that kind of unequal balance of that fluid makes them feel every time they sit up straight, like sit straight up in the bed, they will tell you they feel like somebody just drove a Mack truck into their forehead. You lay them down flat and the pain goes away. So you're thinking, well, just lay them down flat. The problem is nothing is making this go away. It continues to do that. A lot of times they'll try conservative methods to get rid of a spinal headache. I'll be real honest, I've never really seen this actually work, but they'll try to give IV xanthines. IV xanthines are basically caffeine. So they put caffeine in an IV. They want you to vasoconstrict. So hopefully you constrict around that area. You send platelets to the area. The platelets form a plug up the hole, and all is well, in theory. What happens more frequently in my experience with this is that after about a day or two of futile attempt at this conservative method, they end up doing something called a blood patch. And a blood patch is when we take blood from the arm, like the vein in the antecubital space of the patient, and we pull it back into a syringe, and then we immediately turn around and access that same spot in the epidural space. Actually, it's epidural for this one, not subdural. And then they're going to inject that blood into the epidural space, because blood, of course, has platelets and clotting factors and everything that we need for that, a scab to form over where that leaking area is. The funny thing about this is usually a blood patch is instantaneous. 1 minute, quite literally, the patient has the headache, and like a minute later, they start looking at you like they're almost afraid to hope. And yeah, it's true. It takes away that headache. The thing you have to remember, though, is if this person's been kind of laying down for 2 days because their head's been killing them and they haven't been able to really sit up, and now we've given them a new lease on life and they can get up, the problem is they want to overdo. You have to remember that that blood patch is like a scab just sitting there. Have you ever had a scab somewhere and kind of been overzealous in your activity and knocked the scab loose, and how everything starts bleeding again? Well, the same thing can happen here. If they go a little crazy, they can knock that scab loose, and then we're right back where we started with a leaking, cerebral spinal fluid area. So, yes, they're going to feel like they want to do things, but it's our job to allow them to do some things, but kind of keep them reined in, making them understand that too much activity for like the next 24 to 48 hours might not be a great idea. Let's see. Okay. We just already talked about the complication of the spinal headache, but I do want to talk for a second about neurogenic shock. Now, we are going to discuss shock and the different physiologic aspects that go into shock momentarily. But For neurogenic shock, what you're talking about is something is neurologically triggering massive vasodilation in your patient. And we'll give examples, but something is making them fire neurologically, and that result is all of the muscle layers of all of your vessels, the tunica media, all go into relaxation mode. And that problem means that the blood that is going out to the periphery stays in the periphery, and it doesn't come back to your central venous circulation. Of course, the problem with that is if you don't have a lot of blood in your central venous circulation, what do you think is going to happen to your blood pressure? Well, it's going to drop. And the primary sign of shock is low blood pressure. It's not necessarily the first. I'll only say that about 16 more times. But we'll talk about that a little bit more in depth a little bit way down the road here. Other regional blocks can be limb blocks, like a beer block. Notice how it's spelled. We're not talking about a beverage. A beer block is a block that is going to be placed in the axillary area, and it's going to numb not the entire shoulder, but part of the shoulder, but the arm. The whole rest of the arm will be numb. They can also do something called an intrascalene block. They'll go behind the scapula and put in the block, and then that helps to actually capture more of the shoulder. They can also do an ankle block. Maybe this person's having a bunionectomy or something done down on their foot. We don't need to anesthetize the entire person to do a bunionectomy. We can put in a block at the ankle, make the foot completely numb, and take care of it. Same thing with a digital block. If somebody's got something wrong with the last knuckle of their finger, the most distal, or if they've got a fingernail that needs to be removed, or they've got a huge blood blister or something under that fingernail that's got to be taken care of, we can do a digital block. They do a digital block right at the base of the affected finger, and it's really going to just pretty much make that finger numb. We can also do a penile block. A penile block is something that's used if we have to do an adult circumcision or an adult dorsal slit for somebody who's got phimosis, then that's something that we can use. The big ticket item to remember here is on any of these areas like penis, nose, fingers, toes. Sorry, but that's the little rhyme. Penis, nose, fingers, toes. Anything like that that's very peripheral and is a digit, you never use a local that has epi with it because we risk the circulation in that area. So they'll always just use a basic local anesthetic and not anything to go with it. The difference is usually we use lidocaine or lidocaine with epi, and we can't use lidocaine with epi on any of those areas. Now, a local is how we're going to take care of, a lot of basic things, a lot of little issues, small minor surgeries will be taken care of with a local. The other thing a local can be used for, because it can be used alone, or it can be used adjunctively. Even if somebody is having a regional anesthetic for an area, the doctor still might infiltrate the tissue with a local because you'll get better and longer pain relief from that. Even though there's a more wide block taking care of the pain for that procedure, putting a local in the immediate tissue where you're working gives them pain relief for even longer. So it can be used alone as a modality for surgery, or it can be used adjunctively for pain relief, along with usually a little bit of sedation. One of the risks of a local, I just told you, lidocaine or lidocaine with epi, is the fact that that lidocaine can get picked up by the vascular system. And, the point of the lidocaine with epi, this is kind of maybe talking about it backwards, but if you use lidocaine with epinephrine, the epinephrine holds the lidocaine in place. Well, that sounds great. It causes a little vasoconstriction and holds it in place. The beauty of that is the likelihood that that lidocaine then gets picked up rapidly by the vascular system is pretty low. You probably don't know a lot about lidocaine yet. I promise Lisa will be discussing that in cardiac, but the one of the effects of lidocaine on a person is bradycardia, okay? So we don't want this drug picked up rapidly through the vascular system because of the effects that it can have on the heart. So the point and the reason we use epi is to try to hold it in place so that doesn't happen. But I just told you, we can't always use it. There are certain places it's absolutely forbidden, and it's not always appropriate to use it. So sometimes that lidocaine can be absorbed too rapidly into the systemic circulation. What you're going to have there is a patient who's showing you all of the cardiac effects of lidocaine, which will be covered in a future unit. But for right now, you just need to know about the significant bradycardia. There is a really cool new treatment for this. It's called LAST, Local Anesthetic Systemic Toxicity, which means the local anesthetic got absorbed systemically and caused a toxic reaction. The new treatment for that is something called lipid rescue. The rationale behind it is lidocaine and other medications like it are lipophilic, meaning they like fat. So if you give lipids, then that lidocaine will actually bind to the lipid, and when it's bound to that lipid, it's no longer demonstrating its cardiac side effects within the patient. This is expanding as an adjunctive method to reverse other meds also. If there are other medications that we have found that are lipophilic, this is another way that we might be able to fight off a toxicity. You know, it's almost like the idea of using Narcan to fight off opioid toxicity. We're using lipids, literally just IV infusion of fat to fight off toxicity of meds that happen to be lipophilic. So you're probably going to see this kind of expand a little bit more the further into nursing that you go. Okay, let's talk about when they're in the operating room, some of the positions that we have to assist the patients into. One of the reasons I discuss this, now I know you're not going to go in the operating room and actually have to position these people, but sometimes it makes more sense to you if you understand the positioning, why a patient might be complaining that they're sore in a particular area. I've got some photos coming up in some future slides that I hope give you some sense of what I'm talking about, but when we do have an opportunity to meet up, we can talk about these in a little bit more depth. But why do we need these special positions? Well, obviously, if you're coming in for surgery, you want the surgeon to have the best view and the best access possible on whatever he or she is operating on. Well, sometimes that means that the patient has to be in an awkward or odd position so that we can access those areas. Because of that, surgical positioning requires very specialized nursing care to protect the client. My job as an OR nurse was to literally think of every possible place where that patient would need padding, where something could have happened to a nerve. If I didn't pad it, I needed to make sure they were in proper anatomical alignment so that we didn't put undue strain on tendons or nerves. And then all the while all this is going on, I'm also trying to attend to patient privacy. We don't want to unnecessarily expose a patient. If that was your mother or your father in that operating room, you would want us to take the same kind of care. The other issue is circulation. I can't have the arm or leg in a position that might impair circulation. I want you to think about, sometimes you get in a position and it seems comfortable initially, but after a little bit, you're ready to change positions. I'm betting that even though you're probably listening, maybe you're listening to this lecture in a nice comfy chair instead of the hard ones in the classroom, you've probably still changed positions a couple of times while I've been talking. And that's because your body recognizes not every position stays comfortable for forever. The problem is when this person is asleep and they can't move themselves, they can't obey the commands of their body to move and take care of those positioning issues. So as a circulator, I have to foresee what those issues will be and try to put them in the most anatomically correct position that is going to decrease the risk of any type of injury related to that positioning. One of the biggest worries that we have is, a dangling extremity. When they're on that operating room table, I don't know how much you guys have probably not seen them a whole lot, but an operating room table makes a gurney seem like a really wide thing. An OR table is actually quite skinny. And most of the time, if I were to lay the average person on an OR table, you may not realize this, but your arms would not fit on the table. Your torso fits on the table, but your arms would be kind of flopping off to the side. Well, if you're conscious, you're going to fold your arms over your stomach and you're just going to hold them there. But again, my patient's not conscious, and I may have to, the stomach is where I may be prepping for the surgery. So we have arm boards that we put their arms on, or we have different ways to position them to make sure that that arm does not just dangle down on the side of the OR bed. Once the patient is draped, you don't have access to those areas to do continued assessment. Everything's covered up because it's all sterile. So, it becomes a little bit more worrisome to make sure that you've got everything set the way it's supposed to be. So what are some of the positions? Now, we like the term supine, and we use it a lot, but you need to be aware that supine and dorsal recumbent are the same things. And I can tell you that I've heard feedback from students that this is a little tricky one they like to throw on the boards to see, well, does the student really know what dorsal recumbent is? Okay. Dorsal is the back side of something, so when you're on your dorsal side, you're laying on your back. We also call that supine. But I want you to think about if you're laying on your back on a hospital bed that's not extremely padded, where would those pressure points be? Well, one big pressure point would be the back of your head. So usually we don't use pillows in the operating room. We use something, it's actually called like a head cradle, but it's foam, and it literally cradles, it supports the neck and cradles around the head so that we're preventing any undue pressure on the back of the patient's head. Other areas, just staying, with the main torso, the other area to worry about are the heels. If you think about all the way down the body, usually the booty's got enough padding, we don't have to worry about that. And when they're laying supine, they're not sitting up a little bit, they're laying totally flat, so the sacrum is not an issue. But their heels are. So I'm going to have to put some kind of egg crate type material or foam underneath the patient's heels to protect them during surgery. Then you've got the arms. Well, if the arms are out to the side on arm boards, they'll have to be turned palm up. And if they're turned palm up, because that is proper anatomical positioning and that protects the axillary nerve, then you have to worry about the ulnar nerve. Your ulnar nerve is the one that's going right past your elbow. And that one's very easily to kind of injure. So that'll have to also be wrapped in foam or egg crate in some way. And then the arms will have to be secured so they don't fall off of the arm board. So just all these things that you have to think about. You also have to worry about the staff. Once they're kind of draped out, the staff kind of leaning on the patient and putting pressure on them that way. Other things that you have to worry about, Trendelenburg. So it's that same thing. I have a patient who is supine, but now I've tilted the head of the bed down. Well, I'm going to have a safety belt on them so they don't, move or slide. I'm going to really have to make sure those extremities are secure. And how we do that is we will lay a towel over the arm that's on the arm board so the tape doesn't touch any skin, but then we will run tape around that towel just to hold the arm, kind of in place. It's not a restraint, it's just preventing that arm from falling off the board. Reverse Trendelenburg, same thing, just the other direction. Now we have to worry about them sliding down towards their feet. Sometimes they'll add a foot stop to the end of the bed, so instead of just their feet, being their toes up in the air, they'll actually add a panel onto the bottom of the bed. So if we could stand that bed all the way up, the patient would actually be standing on foot stop. But we don't let them do that, and we still cover it all in egg crate, but that just helps with, the risk of the patient sliding. All of these are challenges and, definitely something that a circulating nurse has to learn how to deal with. But by far, the most difficult position to put a patient in and put them in safely is lithotomy. Lithotomy requires the use of stirrups and additional padding. Now, I've got some different kind of stirrups that I'm going to point out to you in the slides coming up. But one of the worries that you have here is, depending upon which kind of stirrups they are, their legs may be up in those stirrups, but their knees are higher than their ankles. And if their knees are higher than their ankles, I have to worry about venous stasis in the lower legs. So I might have to wrestle SCDs or TED hose on these people before I put them in those stirrups. You also have to pay special attention to the hands and arms. When we're putting someone in lithotomy is, what you typically consider your knees bent, like a woman who's going to the OB doctor is going to be in a lithotomy position for a vaginal exam. So normally that's not a big deal, but we want them to scoot down to the end of the bed so that, the doctor can have better access with what they need to get to. The problem is the arms are longer than that bed. So do you, tuck the arms to the side, risking, their fingers getting trapped in the hydraulics of the bed when you try to bring it back up? Or do you try to put their arms out to the side, but if it's a surgery where the doctor has to go top and bottom, for instance, bladder tacks, they will start a bladder tack vaginally, but they will finish it in the lower abdominal region. So they're not going to stand down at the base of the patient. They're going to come up on the side of the patient so they have better visual access. If they're going to do that, you can't have the arms out to the side. So it's very challenging. There are a lot of nerves that you have to worry about potentially injuring, and this is always one of the ones that, takes, believe it or not, more time to correctly position a patient for surgery. Now, this is lithotomy, and those stirrups are ridiculous. These would be the type of stirrups only used in a doctor's office. We'd never use those in surgery. But the position is still correct, and I like that it shows you all three nerve bundles that I have to worry about and protect as a circulating nurse. Now, the picture at the top, those are called candy cane stirrups, and that's because the top of them is kind of shaped like a candy cane. But basically, those have a canvas type strap that kind of cradles the foot, and that's the only point of contact. So the foot is being held up over their head. This is going to be used for, say, a vaginal hysterectomy, because you need the pelvis to tilt so you have better visual access to get to the cervix and the uterus from the vagina. The one on the bottom those are Allen stirrups, and that's actually pretty high. A lot of times we don't have the Allen stirrups up that high. And by the way, it's not just women. Any male who is having any type of urologic surgery is going to be in these types of stirrups also. But those are Allen stirrups. Those are a little bit more easy to position. Now, if you go back up to the top one, they're trying to show this. Obviously, these people are dressed, but what these positions look like. But you can kind of see that arm board that I was talking about, and they've got the blanket over her, but what I can't tell for sure in the picture is whether or not she's anatomically correctly positioned, because to be correctly positioned, her hand should not be facing down, her palm should be facing up. Okay, some other positions. The laminectomy or prone position is the position that they would get into for, say, back surgery, if we're doing a spinal fusion or we're doing some type of disc surgery or something like that. Couple of ways to do this one. If you don't have the new fun like beanbag things, I'll talk to you about those in a second. One of the ways that we can do this is make a diamond support. We literally take 4 blankets or very thick towels that we've rolled, and we will position those towels so they make a diamond. Then you roll the patient onto that diamond, so that if you think of your chin as the point of the diamond, and then as the coming out at 45 degrees from your chin, that diamond support would then support your shoulders and axilla, and then coming out to the side of you, then another set making the rest of the diamond would go down and kind of support the groin area. The issue with that, or if we use the beanbag, and I've got a picture of the beanbag here shortly, to help position them, that's all fine, well, and good, and it's amazing, but you still have knees to worry about and toes. So most of the time, the way we deal with the toes is instead of just padding the toes, we will make a really big roll and put it at the ankle so that the feet just kind of like hang over it. That might be hard for you to understand, but I can talk about that in class if you guys still have questions. The beanbags can also be used for a lateral position. What the beanbag is, it's basically these tiny little, I hate to even call them beans, but they're teeny tiny little granules that are inside of this positioning device. The positioning device is, the outside of it is a nice soft vinyl. It's easy to clean, but it's a soft material. Well, what you can do is, if the patient's either laying on their stomach, when you lay down on a beanbag, the things that you have that need to push the beans out of the way will do that. So for instance, if it's a female laying face down on that beanbag, some of those granules are going to move out of the way to accommodate for any breast tissue that she has. Okay, or if it's a person with a slightly larger abdomen, they're going to move out of the way to account for that. When you get them properly positioned, you hook this beanbag up to suction, and what it does is it sucks all the air out of that bag and turn those granules into basically a hard shell that provides no pressure because it is already perfectly positioned around every nook and cranny of that patient. So we can use that same technology when we turn them on their side. We can fold that beanbag up. You have a bunch of people hold it, so it's either side. And it literally, that beanbag, once you hook it to suction and take the air out of it, it basically turns into a taco shell. So, you're the inside of the taco shell at that point. We can also use tape to help hold the hip in place. We will literally tape it to the bed. And we will use pillows between the legs because we don't want one knee resting on the other knee. If you're lateral, you're side lying. We don't want one knee resting on the other because that would be points of pressure. And then the jackknife, I have pictures of these, so just be patient with me for a minute. The jackknife is a position that takes that lateral that I was just talking about, and it breaks the bed in half. But instead of a V that would dip down where it's concave in the middle, it's a V that pokes up and is convex. So you're literally kind of making them do like a little side bend along with their side lying position. So let's look at some of these. So this is prone, and that is a beanbag laying under him. And this beanbag is big enough that it can support his entire body plus his head. So when they take all the air out of that, it won't be soft and squishy, but it will be like your own little holder for that patient. So they're not going to go anywhere, but it's also not going to be responsible for putting any pressure on any points. And that's another type. That one actually has a cutout for the face, and you can't see it, but there would also be a cutout on the side for the tube to come out, because obviously if they're face down, they have a tube in their mouth. That tube needs a place to go also. But this one I like because it does show the roll that we put under the ankles to keep pressure off the toes. Now here is lateral, and this is pretty typical. You have them on the side. Now what they're showing there is basically tape that's being used across that hip to hold them in place. And then we use the pillows between the legs. You can see that we've got their arm on an arm board. That's actually both arms. There's the arm on the bottom, and there would be some pillows in between, and then the arm on the top. And we would put a strap around all of that to keep them from, those arms falling. And then this one is the jackknife. Now this OR bed has some extra features. Instead of using tape, you can see it actually has a belt strap that applies the same pressure and holds that hip in place. You can also see that they're using a foot stop to keep her feet in appropriate anatomical position and preventing her from being in an extensive position. They're using a pillow between her legs. And then you can also see that on this particular one, they have one of the really cool extension arm boards that instead of having to just take that bottom arm and pile pillows between it and put the top arm on top, they've got another device that will support that top arm. So this is the type of position that they would be in to do a nephrectomy. If we were going after, it looks like her right kidney, that's the position that she would be in for us to go after her right kidney. So why are OR rooms so cold? Well, because we don't want to promote the growth of organisms. I mean, they're not cold, they're cool, okay? The other thing is, if you think about how those people have to dress who are standing at the bedside with the patient, they've got a cap on their head, and yeah, they're thin, but those caps still hold in heat. They've got a mask on their face, and every time you breathe, the heat from your breath is coming right back on you. And then you've got yourself wrapped in a gown, literally from your neck to about your knees. And then you've got gloves that are not only over your hands, but they're over the gown to make a seal there. And then a lot of times you have to wear plastic boots if the surgery is really messy because you don't want to be splashed. So you're kind of wrapped head to toe. It doesn't take very long for a person who's wrapped up like that to start getting pretty hot. And I'm pretty sure that you don't want someone sweating into your open wound. So, we think of it as staff comfort, but it's also about infection control. We don't want them sweating into an open wound. The other things that help with having the rooms a little cool is it does slow bleeding because it will cause the patient to vasoconstrict a little, and it decreases their metabolic and O2 needs as well. Now just remember, in the operating room, safety is really important because the patient cannot protect themselves. The biggest ticket item is patient identification. I remember already in this lecture reminding you that we have to check their armband and check it twice before we send them to the OR, because once they're asleep, they cannot identify themselves. We also want to have the surgical site verified. JACO considers it obviously a sentinel event to do a wrong site surgery. Clearly none of us want to do that, but we go through many, many steps to assure that that does not happen. We need to make sure the records and the chart are completely up to date, and sterile technique. You guys got a taste of that, in fundamental semester, how kind of you felt like we were probably overly psycho about sterile technique. But I guarantee you, if that is you laying on that OR table, you are going to want your OR team to be more than psychotically crazy about the sterile technique, because you don't want an infection introduced into, your operative area. Other things that we have to worry about, everybody probably realizes that we count sponges. We count them every time we throw them out on the table. We count them, several times through the case. And obviously at the end, we count them to make sure we got them all. We also count needles. And if we're opening a large body cavity like the abdomen, we count instruments. And I know what you're thinking. How in the world could you lose an instrument in there? Well, I can tell you, we have been on the hunt for some time for an instrument that, we're using a small pair of clamps to clamp off a bleeder, then some bowel gets pushed over on top of it, and, it's not until we're looking for the instrument that it's kind of found again. It sounds like that's crazy and it's very careless. I want to caution you to be too judgy until you walk in the mile of the shoes of the people who are trying to do those surgeries. Because let me tell you something, a sponge that's bright white on the back of the table is really easy to see. But a sponge that has been put in the patient's body and has absorbed a bunch of blood now looks like tissue, and it is very difficult to see. There's a reason why we count so many things so often, and it's because of that risk, and we want to prevent any of that from happening. I've already kind of discussed the safe positioning and protecting nerves, so I'm not going to talk about that again. And I have mentioned before about the BOVI, the electrocautery device, and the fact that we need to prevent burns. The BOVI has to be grounded, but it also cannot be grounded over metal. So you have to ask the patient, have you ever had a hip replacement, or do you have any metal anywhere in your body? Because wherever they have metal, you want to position that grounding pad as far away from that metal as possible, because you want the current to ground to the pad and not to the metal. If it grounds to the metal, it will be burning their tissue from the inside out. So this picture, there's a lot going on here. Try to show you a couple of things. This, I can tell just by looking at the x-ray, this is a patient who had their bladder removed, and then they had an ileal conduit made, and this is an ileal conduit, it's not a continent diversion. But let me just show you what you're seeing. So obviously you can tell the patient structures. All of these are the skin clips, so they've already closed the patient, but this would be what the incision looks like. All the clips down here that you see in the pelvis are Liga clips. Those would have been used to clamp off the circulation going to the bladder before they removed it. Now this is a stent. A stent is something that it's a tube that sits in the kidney and drains the kidney. And this stent is actually properly placed. The stent is in the kidney, it's coming down, it's going down, and yes, normally it would go down here. But since we don't have a bladder anymore, it is now coming over to where this ileal conduit is, coming out the ileal conduit, and here the excess of it is kind of balled up in the urine bag that's on the outside of the patient's skin. This one should be up about right here. So this one is a retracted ureteral stent. It's not in the right spot, but it's still going in that same direction. This, however, is the booger, because this is the little tail that they sew on the side of lap sponges. Lap sponges are the larger sponges that we use in surgery to kind of soak up secretions and keep an area dry so we can operate on it. And the tail is radiopaque. So obviously when they took this photo or this x-ray, they were concerned about their sponge count, and rightly so. So now all of this suture is going to have to come back out, all of those clips, all of the sutures underneath it that they used to close the patient, and they're going to have to go in and retrieve that lap sponge. That is nightmare scenario, worst case scenario, what we absolutely try to avoid at all costs. Okay, I know there's a few more slides in this PowerPoint, but this is where I'm going to stop this lecture. We will pick up with lecture number 5 coming up.